Hello, my name is Ron McCulloch and I'm a consultant podiatric surgeon who manages and directs a centre which specialises in the condition of Morton's neuroma. And we have a number of very advanced treatments and investigative modalities to try and resolve Morton's neuroma in the safest way possible. In this particular video, I wish to discuss one of the things that really inspired me to look at alternative ways of treating Morton's neuroma, and that is the issue of stump neuroma. So this is a complication from the removal of a neuroma through an open procedure generally, and the open procedure can result in this complication whereby the nerve becomes hypersensitive. What actually happens is that when the nerve is cut, it can become irritated, either because it forms a true stump, which is where the nerve looks to innervate and it forms a small sprouting of very small nerve fibers that creates a ball of hypersensitivity. That's one belief. I believe that can happen. I think the more common scenario is that when you have an operation and the nerve is cut to where it is normal, you will often get some bleeding, and it's very easy for that bleeding to be greater than ideal because it's an area where it can be quite difficult to occlude all of the vessels, and as a consequence, if you do bleed excessively, you can get adhesions around the actual nerve, which can then result in this continued pain after the nerve has been removed. And obviously there are individual factors in that. Needless to say, the meticulous surgical techniques really important, and we use tourniquets and very good what's called hemostasis to avoid developments of complications from a neuroma. But then of course there are also patients who just bleed more. Even when we do an injection, some patients will bleed very little and some will bleed more, and that's just the individuality of the patient. So that can be another factor. The other issue is that some patients just scar more. So there will be some people who form very fine scars which you can barely see following any kind of injury or surgery. And there will be others who develop very significant scarring of the skin. And if they develop significant scarring of the skin, then that means they will also have developed more significant scarring deeper within the tissues. And this is just the way that collagen is deposited and the patient's physiological response to trauma, and it is individual. So these are the kind of factors that can lead to stump neuroma, and it's important therefore to consider things like that. Do tell your surgeon if you tend to bleed more that they're aware of that. Needless to say, if you're on medication that can make you bleed more, you need to obviously make sure that the surgeon in question takes relevant precautions in relation to that. If you scar more and you're prone to scarring, perhaps even keloid, which is very prolific scarring, often seen in darker skin types, or if you have a tendency to hypertrophic scarring, which basically is just an excessive scar but not as bad as keloid, well then your chance of developing a stump neuroma or particularly scarring around the nerve where it's been incised is greater. So these are all things that we can do to avoid a stump neuroma from occurring in the first place, and being as preemptive as possible about avoiding the various situations that might lead to it. Now you might ask, what can you do about things like scarring? What can you do about things like bleeding? And there are specific measures which can be undertaken, and that's probably going to be part of a different video. Because today I just want to concentrate on treatments that I offer and also, what actually happens. So certainly in the UK, the standard treatment within the National Health Service particularly would be to have a steroid injection following conservative care. Of course, that should always be tried, shoes and insoles, etc. And then after that, if the steroid injection is unsuccessful, the patient will undergo surgery. Now the surgery is usually will normally occur on the top of the foot. Some surgeons go through the bottom. That's a different conversation. I don't really subscribe to that technique. But if you go through the top and make an incision, then the nerve will be cut. And as you can see, these bones get narrower and closer together as you get towards the base of the foot. And what basically happens is when neuroma is removed surgically, then the nerve is cut quite far back. Now the implication of that is if you needed to do more surgery and go back in, for example, to treat the stump neuroma, you can't get to it from the top, and instead you need to get to it from the bottom because the nerve is much closer to the bottom of the foot than the top. The reason why we generally don't go through the bottom of the foot is because of the risk of painful scarring. So the typical approach is to remove the nerve in an open procedure, and then if there's a complication, to try and manage that in conservative ways or medication, etc. But if it doesn't resolve, then the typical UK approach would be to perhaps go in and do a plantar incision so that you can get further back and remove more of the nerve. Now, the negative with that is that if you do that, you will then leave a scar underneath the foot, and that scar can be painful. And it's very typical for scars not to heal that well on the bottom of the foot. They can do, of course, and there's things we can do to maximize the chance of that, and that involves being non-weight bearing for prolonged periods of times, inconvenient but a necessary measure. And there are also obviously dressings and silicons and things we can do to reduce scarring. But nevertheless, if you go underneath the foot, there is that risk, which is why I personally try to avoid it at all costs. And I think many podiatric surgeons do. But the situation is such that patients come and see me often when they've had an incision on the top of the foot and they've developed a stump neuroma. They usually would have had that done in under centers. And as a consequence, they're very distressed because there is a lot of pain in that area. And really, the surgeon's not necessarily that keen to reoperate. And so they're slightly stuck about what to do next. And unfortunately, quite often, the level of pain can actually be more than the original neuroma, which is, of course, extremely distressing for patients. And that's really one reason why open surgery should very much be left as a last resort, and techniques like cryosurgery, radiofrequency, and less invasive techniques should always be tried first. Because if you are unlucky and you develop this kind of significant complication of stump neuroma or scarring around the nerve, then it is going to be a challenge to manage. And it could have potentially been avoided by having a minimally invasive technique. That may or may not have worked, but there's a reasonable chance, certainly from our center, there's a good chance that it would have worked and therefore avoided the need for more extensive open surgery. Now, the question, of course, that people will be asking is, what do we do? How do we treat stump neuroma when patients present to our center with that? My personal experience is that our center very rarely, if ever really, experiences stump neuromas when I've operated on patients in the center. We do use a very meticulous technique. Usually when I do open surgery, the neuroma is very bad, so it's very unlikely that you'll be worse off because the more straightforward neuromas tend to respond to minimally invasive surgery. But we do see quite a number of stump neuromas attending the center, or complications from open surgery attending the center where the surgeon elsewhere has done the procedure. The procedure has been unsuccessful, and then they've been disinclined to offer more surgery, certainly as a last resort, and they've warned the patient about the risks. The patient starts searching elsewhere, and often they come to our center where we will then offer a number of treatments. Now, what are these treatments? Well, firstly, it's always important to determine why the problem is occurring. And usually and often these problems do occur because of underlying biomechanical predisposition. In other words, a predisposition with the way that you walk, the way that you load your foot. And trying to understand the underlying cause for that is complex. I mean, it may be straightforward, but often it is complex. So we perform very advanced analysis using gait facilities, including 3D Vicon technology, which then allows me to analyze and determine why the problem is occurring. And this will be covered in different videos, but certainly, we'll be looking at everything from a neural issue that might even be coming from the back, to hip issues, to things like hypermobility syndrome, where there's a lot of laxity, to specific structural deficiencies within the foot leading to overload. And if we can really pinpoint what the problem is and what's causing it, there's more chance that we can deal even with a stump neuroma, because often these conditions don't heal because the underlying cause hasn't been addressed. So, we do have a specific website on gait analysis anyway, and I think it's really important to bear in mind that we need to know why it's occurring. Let's say we've done that and you have this stump neuroma and symptoms continue and we need to do something invasive. Well, the first treatment approach that I often consider is a diagnostic injection, which involves injecting the area that I think is causing the problem. And if all the pain goes, then we know we've pinpointed the location of the problem. This is all done under ultrasound guidance. Now, if when I do these type of injections, there is a lot of scar tissue, a lot of adhesions around the nerve, and I can feel those with the needle, then I will often consider something called hydrodissection. And what this basically involves is using high pressure from the syringe and from the needle to actually push some of the scarring and dislodge some of the scarring away from the nerve. This is a recognized technique. It's offered in different clinics, and it is a good option. Why? Well, first of all, hydrodissection is very safe. You're just injecting fluid, anesthetic, maybe some saline. You can put some steroid in as well if you think that's necessary to break up the scar. It just depends on the situation. But it is generally, a very safe procedure, and it is dealing with the physical adhesions and scar tissue that may be in the area. The second approach would be that if it is possible to actually diagnose the problem through a diagnostic injection. And remember, when I do diagnostic injections, you put a very small amount of local anesthetic in, so you can really pinpoint where the problem lies. Again, of course, using ultrasound. And this is where you need a lot of experience in ultrasound to be able to do this accurately, and why not everybody can do it. But if I can pinpoint the issue, then I would often consider cryosurgery, because if we can go behind the stump and break it down and break the nerve down and desensitize it with cryosurgery, that can often be successful. And again, it's all about risk, and the risk of that procedure is extremely small and the potential benefits are significant. So therefore, cryosurgery would always be the next step approach if there is evidence that we can locate the problem in that manner. Much better option than open surgery. I also do open surgery, of course, but I really leave this as a last resort option. Okay. Now, let's say that the cryosurgery has been partially successful, then we could repeat it. And unfortunately, with stump neuroma, sometimes the procedure does need to be repeated a few times to really desensitize the area. Now, a significant percentage of our patients will often respond favorably to the last two approaches that I've mentioned, in combination with dealing with any underlying issues. Okay. But if the symptoms do not resolve, then we still have another minimally invasive technique, which would be radiofrequency. I tend to leave ablative radiofrequency, which is effectively a hot tip needle, as a third option, because obviously when you go in with the needle and you burn through a section of the nerve, you could create some scarring, or you will create some scarring compared, for example, to cryosurgery and hydrodissection. Doesn't mean it won't work, but there is a bit more risk compared to cryosurgery and hydrodissection, and so I leave it as that final option. I still think it's a much better option than going for open surgery. The real issue with open surgery is if you've made the incision on the top, now going to go underneath the foot, and that doesn't work, then you have a scar on the top, you have a scar underneath, and you've really opened up a whole range of potential issues which can be extremely difficult to resolve. And the most significant and unfortunate complications that I see in our facility is patients who have gone through this process and are still not better. And, sometimes, unfortunately, it's because something's been missed. Sometimes there's an additional nerve. Sometimes another nerve in the foot is causing the problem. Sometimes the patient may have something called tarsal tunnel syndrome. So these are all things that have to be very carefully evaluated. But these patients who present with, multiple scars, multiple incisions, and are still not better are the absolute worst outcome, I guess, in terms of localized issues following Morton's neuroma. And this is why it's so important to consider these minimally invasive techniques before moving on to open surgery. Finally, I just want to discuss something called the double crush effect. Now, this is a recognized phenomenon. Now, what sometimes happens is that patients will have hypersensitivity of a nerve because of a neuroma, but there may be other factors that are influencing that hypersensitivity. So, for example, patients may have nerve entrapment higher up around their spine. They may have a slide disc issue. It may not even manifest as back pain, but they may have some catching of the nerve higher up. And then what can happen is it can be the cumulative effect of local impingement higher up on the nerve, local pinching on the nerve higher up, combination with the neuroma that finally leads to symptoms. So sometimes if you remove one of the causes, the pain will go down, even though the neuroma may still be there. Now you may think, well, that doesn't make sense because I've got a neuroma. Well, bear in mind that a very significant percentage of people have asymptomatic neuromas. It's all about the size, the space, and how irritated it is. But just because somebody has a neuroma doesn't mean that it has to be removed to get rid of the pain. And sometimes there's a cumulative effect, as I say, this double crush effect. So when that happens and the patient has a double crush kind of injury, we need to consider treating the nerve in additional ways, so to reduce its sensitivity around the spine or wherever that's occurring. And that's where my physio team comes in, very much to try and deal with that aspect of things. We normally analyze those things and diagnose them as part of the clinical assessment. We will find out why it's happening because of advanced computerized gait analysis, and then by incorporating the input of physiotherapy, and that can really make a difference to, again, treating the problem holistically. So I hope you find this video helpful. There is hope if you have a stump neuroma. We have decent success rates at the clinic with all of these type of assessments, and do reach out and contact us if you would like to have more information.